Hi there. Okay, so first of all, before we go on, we're here to talk about chest pain. So if you're having any kind of chest pain that's got these following things, I need you to go away and I need to talk to your in-person ER physician, not to me, okay? That's if it's substernal, under this area, radiating to your jaw, your neck, the left side of your arm, if you have a past history of any kind of heart attack, if you have a family history of sudden cardiac death where somebody died before the age of 50 for no reason, if you have pain that you're sweating while you have it, you've got some nausea at the same time, and it's not sharp, it's crushing, kind of like there's something sitting on your chest. Okay, all of those things radiating to that side up here, kind of is hard to breathe, not because of your lungs, but because there's something like just crushing on your chest, and it's just a squeezing, nasty pain. All of those things, you need to go, not talk to me, okay? Go to your doctor, okay? Otherwise, hi, I'm Jen. I am an actual doctor. You can see my NPI number and my license number below. And I wanted to kind of hear a little bit about your chest pain and have kind of our little visit in the world of internet white. Now I'm whispering because I was never here. You and I never spoke, and I am not giving you medical advice because I've never seen you face to face. Okay, this is our special world, and we have to keep it that way. Air quotes, equal air quotes. Okay, I'm fairly good at figuring out and fixing non-cardiac chest pain. That's chest pain where you've been to the doctor over and over and over again, and for some reason nobody can figure out why your chest hurts. That's like that's where I'm good at that. But for those other things that I said, that's not me. You need to go to the ER immediately. Okay. All right. Now we've got those introductions out of the way. There's studies that show that doctors almost never let patients talk. We start talking within like 30 seconds of coming into the room, which is completely inappropriate because how do we know what's wrong with you if we haven't listened to you, right? I totally agree. So, tell me about your chest pain. Just get it all off. Get it all off your chest. Okay. Roger. I'm sorry, man. That really sucks. Absolutely. Well, let's figure it out. Let me ask you some questions first, and then we'll listen to your heart. Okay? And by then, you should be relaxed and on your way to sleep. I want this to be informational, but also relaxing, and that is why I am whispering and speaking softly, okay? It's a little strange. I'm sure you've never had a doctor that does it like that, but I choose to try to be different. Okay. All right, so, where is your chest pain located? Okay. Oh, you can pinpoint it with a specific. Okay. Oh, but you have a different chest pain that's also kind of all over and like squeezing, but not crushing. Okay. That is a little bit like tightness. Ah, okay. How long does it last? Okay. It'll be like one consistent episode lasting for like an hour. Okay. Does it change when you walk? By that I mean like as soon as you get up and you're walking, you feel like any of that crushing that we talked about earlier and you need to go away and leave me alone? No, it's more like you are squeezing. Okay. And it's not really changed by walking. Okay. If you push on it or if someone else pushes on it, does that make a difference? Okay. So, how about, does it radiate anywhere? And what happens right before you start it? Okay, take a quick break, and I'm gonna go ahead and type some of that stuff in right here. This is my little computer. Yes, this is Google. Let's go ahead and look it up in Google. No, I promise I'm not doing that. There is a special Google for physicians called UpToDate. if you can somehow get a login in there, it's got really useful information that physicians like to kind of hide from everybody. It's not like WebMD, it's like the real thing. But yes, there is a Google for physicians. That's not what we're going to use right now. Go ahead and type up some of this stuff you said. And yes, I have an Alienware. I'm sure most physicians do not. Yeah. Okay. Let's get to the information. Because those of you who aren't here for ASMR are like, what's going on? When are you going to tell me useful things? Let's talk about what could be causing your actual chest pain. So first off, a constricting pain could be, it could be angina, like cardiac. So constricting pain is important. A lot of times it can be anxiety. That's an important one. And no one wants to be written off as anxiety. So we always look at the other physical factors first, right? So constricting pain can go either way. It can be a cardiac thing. It could not. Something to get further workup for. A sharp pain is actually typically pretty reassuring. A sharp pain, like right in one specific area, can be something called costochondritis, which is actually, it can be something where sometimes you need a massage therapist or like a DO physician or someone who can do OMT to kind of put it back in place. It's just things are a little bit out of alignment. That can actually happen with a sharp pain. Another thing can be the pleura. That's the area around your lungs. If your lungs are inflamed, like you have pneumonia or something like that, and it's a sharp pain that changes every time you breathe, and you've also got a cough, you've also got some, just in general, like it hurts when you breathe, that's different than the difficulty breathing of like a heart attack. Difficulty breathing of heart attack feels like something is crushing you and so you can't breathe. The difficulty breathing of a pneumonia is more similar to every time you breathe, it really hurts. Something sharp, like, oh, especially taking that deep breath. Oh, and you can't really take that deep breath. Sometimes if you just have a very bad flu or a pretty bad cough, which can really, really suck, you can get those kind of sharp pains. But when you cough, okay, that's all reassuring for non-heart attack stuff. It's still miserable and terrible, but it's reassuring for non-cardiac things. Kind of help you feel a little bit better. Definitely, again, prolonged crushing tight, intense, that you need to go to the emergency room. Okay. And if you go to the emergency room, they'll usually take, and what they should do is they should take something called troponins. That's a blood test that they should take to see if the heart lining is breaking, not the heart lining, but the heart muscle is breaking down. And they'll take an EKG. I'm going to just show you kind of what a normal rhythm looks like, okay? See, this is normal little rhythm. This is going to show up, I think, a little backwards for you, but there's a little P wave. It's got a good distance from this tall wave. The tall wave is called the QRS wave, and that's the T wave, right? And they all have to be right side up like this. They all have to have normal distances from each other. They all march out, okay? And that's like what a normal rhythm looks like, okay? Normal sinus rhythm. But that's kind of what a normal one looks like. For sudden cardiac deaths, about 50% of them are due to an anatomic abnormality, which means that's something you would know about in your family. So when you go to the physician, mention family history. Any deaths under 50 years old, very important. Things like sudden drownings, where like the person could swim. Why did they suddenly drown? Single car accidents, the person had no reason to just suddenly be in a car accident by themselves, single driver alone. Or somebody randomly collapsed, fainted, and died. Those kind of family things before the age of 50 put you at increased risk for a cardiac condition. Okay, so those are things you should know. Your only, as far as sinus rhythms, a lot of people, especially young athletes, when they get their EKG, they'll be told they have bradycardia or a slow heartbeat, even as low as like high 40s for a very young athletic person. That's kind of low. That's pretty low. I feel squicky if someone has something that low. 50s, even those can be normal for somebody who is very, very athletic. Only about 7% of sudden cardiac deaths are actually in any way related to any kind of So that's not a concerning rhythm, especially if you're young and athletic. Now, if you're older and you have a very, very, very slow heart rate, that is concerning. That is a little odd. Okay? It can be. It doesn't have to be. Slow is relative. We're not all the same. A normal heartbeat is usually between 60 and 120 beats per minute. 120 is high, I'm sorry. 60 and 100, not 120. Excuse me. Excuse me and my terrible brain. Okay. So that's kind of where normal falls, but people are often outside of normal. I don't like outside on the high range. Outside on the low range can be because you're athletic. Okay. So those are all kind of reassuring things. If you have none of those features, none of that family history. Now, there is something called heart score that we can calculate to see if things seem more like cardiac. I'm going to show you, this is something your physicians will calculate when you go, if you go to the ER, sometimes if you go to your PCM, but not usually. But I'm going to show you, and you can actually find it online yourself. This is the website, it's mdcalc, okay, .com. And this is like where physicians will be like Googling your stuff. So it's not Google, I promise. Sorry, I have a lot of things here. So we'll go through it together, kind of think about it. There's also something called a TIMI score and a Framingham risk score. The heart score is more commonly used, fairly validated. Okay. So the first thing we ask is your history. Is your history slightly suspicious, moderately suspicious, or highly suspicious? We determine that. That's not just a feeling like, oh, is it slightly? We determine that by something called your Diamond-Forrester criteria. And that's involving the things that I said at the very beginning that you need to look out for. Does it get worse with exertion? There's another one where does it get better or worse with nitroglycerin? And is the nature of the pain like substernal, crushing, things like that. Why is it called Diamond-Forrester? Because that's the name of the old guys who came up with it. That's just how it is. So if it meets 3 of those criteria, then it is typical angina, like typical chest pain for cardiac, and that would be highly suspicious. If it meets 2, then it is atypical, which in women, people who have diabetes, okay, an atypical chest pain can still be a heart attack, okay? Especially if you're a woman, sometimes your chest pain will be like down under here, like down right here instead of up here, okay? Still that same crushing chest pain, that sense of doom, that radiating, like those kind of things. You will not be hyperventilating though, which is important. You will more be like, I mean, you can be, anything can happen, but it's a kind of different. It's like, oh, it's like hard to breathe because it's heavy. It's not like when you're like, and you're doing this fluttery feeling. Either way, if you have those things, it's good to get an EKG. Just go get an EKG, rule things out. I think it's better to err on the side of caution, right? Because in women and people with diabetes, you may not have those same symptoms. So just get an EKG, get it checked. Just make sure it's not cardiac, right? And sometimes you'll get those blood draw, that troponin. Okay, yeah. Why people with diabetes don't have that? Because people with diabetes often have some nerve problems and they can't feel basically their chest pain. And people with diabetes are higher risk. Other groups that are higher risk for cardiac incident, people with hypertension, okay, coronary artery disease due to hyperlipidemia. Okay, so those are all good reasons to kind of get that emergency check. And we can talk later about how to prevent those and have improved heart health a simple and non-stressful way. So those are kind of your heart things. Let's go. So that's, going back to the risk score. Your heart score can be slightly suspicious, moderately suspicious, or highly suspicious, depending on those Diamond-Forrester criteria. And that's how the doctors are thinking about it. Okay, so slightly suspicious, you just have one of those 3 things: the nitroglycerin, the walking, or the substernal pain located in the chest. Then you get your EKG and this is, they check and see, was your EKG normal? That adds a 0 to your score. What's your age? If you're under 45, you don't get a point. If you're 45 to 64, you get 1 point, and over or equal to 65, you get 2 points, right? Then you go to risk factors, the ones I mentioned: hypertension, hypercholesterolemia, obesity, that being a BMI over 30 kilograms. Do you smoke? Do you have a positive family history? And for this test, it's if you have a parent or sibling who had coronary artery disease before the age of 65, okay? Atherosclerotic disease, if you've had a prior MI, if you'd had a PCI or CABG, that's where they have to put a little sharp thing up through one of your arteries to go all the way up into your heart and unblock stuff, okay? A CABG is where they actually have to do the bypass surgery. If you've had that, you have higher risk. If you've ever had a stroke, right? Or if you have peripheral arterial disease, those all increase your risk. So if you have 1 to 2 risk factors, you get 1 point. If you get more than or equal to 3 risk factors, you get 2 points, right? So this is just, I'm going through these things to kind of help you understand why it is that physicians will rule you out for cardiac. These are like very in-depth things that we do. One thing that we are pretty good at is ruling out cardiac things. What we are not always so good at is figuring out why do you have non-cardiac chest pain? It's really bothering you. How do we fix it? The last point in this heart score, which again is kind of a little thing that they use to see, should I be admitted to the hospital? What should happen to me next? The last point is your troponin, and that's those little basically pieces of heart molecule that I talked about. That's checking, and if you have a high troponin, then that's obviously a risk, right? So if all of these things come back, even if you just have some risk factors, so let's say you have 2 risk factors, everything else is normal. Let's say you have one, you have a moderately suspicious history, you have some atypical pain, gives you 2 points. So your risk of basically a major cardiac event is less than 1.7%. That's fairly good. So I hope that's kind of reassuring. You can kind of figure out and calculate. And again, you can go to mdcalc.com heart score. You can go to like the Framingham risk score is another one for hard coronary artery disease. That one requires your cholesterol. That's an older score, not used as much anymore. And then another older score is the TIMI, which you can find all of those on the MDCalc. But that's kind of to give you an idea of why physicians will rule things out. And sometimes you'll come up in these intermediate categories, and so they'll want to send you for a stress test or sometimes an echocardiogram. But that's really only if you come in these kind of like higher intermediate risk categories. Otherwise, you really don't need those things. It depends, right, on these scores, on your family history, those kind of things, okay? So we've kind of talked about the things that make, the scary stuff, like a heart attack, less likely. Let's talk a little bit about, other chest pain. So they've already ruled those things out. They've already done a chest x-ray to make sure you don't have pneumonia. You've kind of already gotten some of these, scores and information and other kind of things out of the way. Why do you have chest pain, right? So a very common cause of chest pain that I see can actually be because of your GI system, right? This is not as common as the one I'm about to talk about, but this is one that you can see. If you have burning pain right down the middle or right up here underneath, for a female, right, like kind of underneath where your breasts are, right in the middle, or maybe more on the left side under your breast, but it's burning pain, not crushing, burning like it is on fire, and it is really bad. I had attending another physician who was sitting and talking about his chest pain one time, and he talked about how, like, yeah, I understand why people go to the ER for GI pain and think they're having a heart attack, because I had some indigestion the other day. I thought I was gonna die. Yo pensé que yo iba a morir. This was in Puerto Rico, and different populations, depending on what you're eating, you can have a higher likelihood of having these GI issues. Okay, the research has shown if you have that burning pain about half an hour, 40 minutes, right after you eat food. The most common culprits are spicy food, greasy food, things like that. Or you have a sense of something coming up at the same time. That's more likely to be a GI issue, and we will do a visit entirely about GI issues. Okay. If your pain is more sharp in the one location, like we talked about, costochondritis. Now, what a lot of physicians do that tends to piss off a lot of my patients is they will say, "Oh, it's just costochondritis, go away, nothing I can do about it." And my patients are like, "It's not just, whatever it is, it really, really hurts. Something is actually wrong." I'm very sorry if you've ever had a physician kind of blow you off in the past. Yes, even costochondritis can be something very, very wrong. It can feel really awful. So, sharp chest pain. Let me show you. May I press on your chest? Okay, so if I push on the area of the pain, right, like on it, okay, does that cause you to have the pain? Yeah. That is a good indicator for something like costochondritis. You don't have any trauma, nothing like, not likely to have a fracture or something like that. Okay. Sometimes the weird things get missed, right? Like if you're an older lady, maybe above, nice and experienced, above 80 or in your upper 60s, and you didn't have a fall, but you got that sudden chest pain there, but it's very strong and it hurts when you breathe, and you have a family history of cancer, and again, I know this is a very specific scenario, then you want to look at, make sure they do an x-ray just to make sure you don't have anything there. Older women, we can sometimes have like tumors or other things that are in the bone causing a fracture, and you wouldn't want to miss that. Again, more likely in an older person, and that's like if I press on you, you like scream, you can't even, and breathing hurts and everything else like that. But with just pressing and it really hurts, but I can muscle through it, and it hurts all along this area. So like me, I always have chest pain, actually, almost 100% of the time, and it does get worse when I breathe because I have certain medical conditions that cause that. But like with me, you press along the side and it really hurts. You can't really have people pushing on your chest, or someone pushes in the middle and that really hurts. There are ways to treat that. So costochondritis is inflammation in the chest. I always have it because I have certain inflammatory conditions. It's not fun times. One way to treat it is with anti-inflammatories. I like anti-inflammatories that don't cause as much gut damage, like celecoxib or Celexa. Sometimes you'll find the high-dose ibuprofen at 800 milligrams prescribed by your physician is enough to kind of help out. You have to take it for a little bit before that inflammation goes away. Sometimes you'll have that inflammation after you had a cold or after you had a pretty intense activity, but you didn't have a trauma. Your body just is reacting to it. That's costochondritis. Sometimes you will have that inflammation can be because just something is a little tweaked, a little muscle out of place. I'm an MD. Many MDs do not understand or have a good research background into things being slightly out of place, right? So your chiropractor can sometimes fix that. But if you want a physician and not a chiropractor, somebody who can do everything an MD can do, and has that training. A DO is a physician who's like an MD who isn't basically an MD plus, they're an MD plus, they know kind of some of this alignment stuff. I do this alignment stuff because I was trained by DOs. And what I found, I've had patients, I had a guy who had chest pain for, 3 years. And nobody could figure out what it was. He had full cardiac workup. It was awful. And the way he described it, people often were wondering if there was something cardiac wrong with him. Couldn't find anything. We sat and we talked. In fact, when he came into me, people were freaking out. They thought he was having a heart attack. He was not having a heart attack. He had a normal EKG and normal past history. We sat down, we figured it out. We kind of made sure everything was normal. And then I started to ask about the things that make it better or worse. turns out, he said sometimes it gets better after a massage. And I'm like, ding, light bulb. I don't know if that's what a light bulb does, right? And I actually was able to put the rib back in place and fix it. And he was like, wow. So you may need a physician who can do that. You may need a DO physician. Most of your MDs are not trained in that. You can go to www.osteopathic.com. You can find an osteopathic physician that way. And that can help. Some people just have, this particular person had a surgery many years ago that just kind of made it so his stuff was tweaked. His stuff was kind of moved out of the way. I can basically talk about it in more complex terms than that, but that's the simplest way to put it. His stuff was tweaked. And so every now and then it just needed to be put back. Doing regular exercises to strengthen the muscles to hold things in place can also help, right? Having, good exercises for your pecs, good stretches, things like that. So that solves a ton of the problems of people I've had who just have this always chest pain. It's so annoying. For my chest pain that I have, it gets very bad sometimes where I just have to curl over and cry. A lot of times what I need is the soft tissue needs to be basically manipulated because it's a soft tissue issue. In my case, I have a nerve sensitivity where I will feel things that I shouldn't feel. It's a unfortunate and stupid disease, but and so sometimes just getting that realigned helps. Sometimes I just need a nerve medication, okay? Or something realigned. So those are kind of other things to think about. Do not go asking your physician about your chest pain and asking, do I have a nerve condition? They will not understand. A better way to kind of approach your physician about it is to be like, look, I understand my chest pain is non-cardiac. I really don't think it's emotionally based. Can I get a referral to chiropractic, or can I get an evaluation? I also, if you have pain all over, ask for evaluations about chronic pain syndromes like fibromyalgia or other things like that, if it's not just in your chest, okay? If it's just in your chest, those things I mentioned can be very helpful, okay? Another thing we need to talk about is anxiety and panic attacks. No one likes to talk about this. Everyone feels you're being brushed away if your physician tells you, oh, it's probably just a panic attack. Nothing. Having had panic attacks in the past myself, again, nothing is just a panic attack. That is the worst. That is terrible. No thank you. Not just a panic attack. So your panic attacks they can occur without you feeling panicked at first. You can have a trigger. I had one time when I just walked outside and all of a sudden, and I saw a bunny rabbit. It's the stupidest panic attack. I saw a bunny rabbit, and all of a sudden, it felt like the entire world was trying to eat me, and everything was going to swallow me up, and just started to, I had to curl up and just cry, right? It may not be like that for you. A lot of people with panic attacks, they will not have a strong emotional reaction until the panic attack starts. They'll just be doing their thing. All of a sudden, the heart is going really, really fast. You're starting to breathe really, really quickly for no reason. Maybe your chest hurts a little bit, and but it'll be like a tightness. Okay, it won't be a crushing pain. That again, please go to the ER. It'll be kind of like that tightness, and it'll sometimes be a very bad pain, but it'll be like this squeezing. And if you can't tell the difference between squeezing or crushing, again, go to the ER, please. Please, don't die because you saw a YouTube video. And just that kind of constricting, like that kind of fast breathing that's like up here instead of the instead of that, like that one. And then you start to feel scared, having those palpitations. I had a patient. It took forever. It took a very long time, lots of workup to figure out what was going on, why he had these, because he wasn't feeling anxious until they happened. And so he was convinced, like, this can't be emotional, like, what's going on? we later found when all the other workup was negative, we were able to get rid of his symptoms, getting rid of the chest pain, the palpitations, everything like that, when we got him on appropriate antidepressant medication and got him talking to somebody. They started to go away. Sometimes your body just does that, and then you start having more and more of these, and you're like, what is going on with my life? My life was normal before this. It can be really debilitating. So it's never just a panic attack. It doesn't mean you're crazy. It doesn't mean that you can't tolerate things. It means that your body has decided this is what it wants to do, which is very unfortunate. So that's kind of the panic attack. Now, anxiety, you can have that, and this is something I get also. So I also know it's not just, oh, that thing. I know I'm sick with everything. It's not just anxiety. I'm not usually an anxious person. If I do get an anxious moment, I'm not an anxious person. I don't have generalized anxiety disorder, any of those things. But if I get these strong anxiety moments, which is not really a panic attack, you get this just in the middle. You can have this difficulty breathing, kind of in the middle, as if it were that burning for a GI issue, a gastrointestinal issue, but it's not burning, it's just tight. And you just like feel this sense of doom and without that crushing, with a normal EKG, all those kind of things are normal, right? Always check that, please. Always check that. Right? Those kind of things, that can be really, really unfortunate. And again, sometimes you just need other treatment. It could be a medication, it could be a lifestyle change, and we can talk about that. We'll talk about lifestyle changes for panic attacks at another time. It could be, it could be a lot of different things, but that can help, basically. So those things are treatable. So you don't have to just live with your chest pain. This is kind of the bottom line that I wanted to emphasize. You don't have to just live with your chest pain just because it's non-cardiac. You can have other chest pain. And by the way, there are more kinds of cardiac emergency than just a heart attack. You can have an hypertensive emergency where you're having pain because you're too hypertensive, right? And so I think, does this kind of answer some of your questions about chest pain? I hope this was informative. Okay. I think what we'll do is I will listen to your heart and lungs next visit. Okay. Since we did a lot of talking now, it's already been about 40 minutes, and I was supposed to keep this to 20 because I'm trying to practice. Keeping things short. So we'll do that next week, okay? And we'll talk a little bit more about chest pain, just kind of answer any questions you might have, okay? Absolutely. And you can put your questions down in the comments if you want. Again, I was never here. This is not a medical visit. It's a secret. And you're not getting medical advice, okay? All right. Thank you for coming in. Again, there are so many other ways that we can talk about chest pain. I think after we do the heart exam next week, maybe the week after, we can talk about GI stuff. Whichever thing in this little visit you wanted to address, we can address, okay? Alright. Thank you very much for stopping by. And please, please, please take care of yourself, okay? You are the only one of you. Even if you have a twin, you're the only one of you. And you're a very precious resource. So take care of yourself so that you can take care of the rest of us.